Question 1. A 56-year-old male, Mr. Thompson, presents to the emergency department with sudden onset chest pain radiating to his left arm and shortness of breath. He has a history of hypertension, smoking, and diabetes mellitus. His vital signs are BP 150/90, HR 108, RR24, and SPO 92%. An X shows since segment elevation, a Roman termina, and F. Most appropriate immediate action for Mr. Thompson: A. Administer nitroglycerin to reduce chest pain. B. Perform an immediate percutaneous coronary intervention ECI. C. Administer aspirin and contact the cardiac team for urgent evaluation. D. Initiate CPR and prepare for defibrillation. Answer: C. Administer aspirin and contact the cardiac team for urgent evaluation. Explanation: Mr. Thompson's presentation is highly suggestive of an acute and segment elevation myocardial infarction (STEMI), as evidenced by the typical chest pain pattern, risk factors, and ECG findings. The initial management for STEMI involves administration of aspirin to reduce platelet aggregation and initiating contact with the cardiac team for intervention e.g. ECI. Nitroglycerin may be given after ensuring there is no contraindication e.g. hypotension, but it's not the first-line intervention. Immediate PCI, option B, would be the next step after evaluation, but it's not the initial action. CPR and defibrillation, option D, are reserved for cases of cardiac arrest, not for patients with STEMI unless they become unresponsive or go into arrest. Question 2. Which of the following is a critical consideration when managing a patient presenting with anaphylaxis? A. The patient should be monitored for 48 hours post-administration of epinephrine. B. Epinephrine should be administered intramuscularly, preferably in the anterolateral thigh. C. Antihistamines are the first-line treatment after epinephrine for symptom relief. D. Corticosteroids should be administered immediately to reduce inflammation. Answer: B. Epinephrine should be administered intramuscularly, preferably in the anterolateral thigh. Explanation: the first-line treatment for anaphylaxis is intramuscular epinephrine, which should be administered into the anterolateral aspect of the thigh, as this site allows for rapid absorption. This should be followed by supportive care, including oxygen administration, Roman ruids. Monitoring for 48 hours, option A, is not routinely unless there are concerns for biphasic reactions, which are rare. Antihistamines, option C, are secondary therapies and should not be relied upon for initial treatment. Corticosteroids, option D, are often given as part of the treatment, but they are not effective for immediate relief and are not the first-line intervention. Question 3, scenario-based. Mr. Garcia, a 38-year-old male, presents with a traumatic head injury after a motor vehicle collision. He is conscious but disoriented with a WESA 13. He has an obvious laceration on his forehead and reports a headache. On examination, clear fluid leaking from his right ear and bruising around his eyes. What is the most appropriate action? A. Apply direct pressure to the ear to stop the leakage. B. Immediately intubate the patient to secure the airway. C. Perform a canny of the head and spine and consult neurosurgery. D. Clean the laceration and administer pain medications before further evaluation. Answer: C. Perform a K of the head and spine and consult neurosurgery. Explanation: Mr. Garcia's symptoms suggest possible basilar skull fracture, given the clear fluid, likely cerebrospinal fluid, leaking from his ear and the bruising around his eyes, raccoon eyes. The most appropriate next step is to perform CT scan of the head and spine to assess for fractures, intracranial hemorrhage, and other complications. Neurosurgical consultation also warranted due to the potential for significant brain injury. Applying pressure to the ear, option A, is not recommended as it may exacerbate intracranial pressure or further injury. Intubation, option B, may be necessary if the patient's airway becomes compromised, but it is not the first intervention in conscious patient with GCS of 13. Cleaning the laceration, option D, should be deferred until full neurological assessment and IM are done to rule out skull fractures and intracranial injury. Question 4. A 25-year-old woman presents to the emergency department after a fall from a height. She is complaining of severe back pain and has difficulty moving her legs. On examination, she has a weak and absent lower extremity motor function and decreased sensation below the umbilicus. Her vital signs are stable. What is the most appropriate initial action? A. Apply a cervical collar and perform a thorough neurological assessment. B. Administer intravenous fluids to manage hypotension. C. Perform a full range of motion exercises on the lower extremities. D. Place the patient in a prone position for comfort and pain relief. Correct answer: A. Apply a cervical collar and perform a thorough neurological assessment. Explanation: given the mechanism of injury, fall from height, and the neurological deficits, weakness, and absent motor function, the patient is at high risk for spinal cord injury. The initial management involves applying a cervical collar to stabilize the neck and prevent further injury to the spinal cord, followed by a detailed neurological assessment. The extent of the injury, Roman IIIDS option B, may be necessary if there is hypotension, but this is not the primary concern in this case. Full range of motion exercises option C and placing the patient prone option D may exacerbate spinal cord injury and are contraindicated without proper spinal immobilization. Question 5. A 67-year-old male with a history of congestive heart failure CHF presents to the emergency department with increasing shortness of breath, orthopnea, and bilateral lower extremity edema. His vitals are BP 145/90, HR 112, RR 22, and SPO 91%. Which of the following is the most appropriate treatment for this patient? A. Administer Roman IIDS to restore circulation. B. Administer nitroglycerin and furosemide. C. Initiate epinephrine for anaphylaxis. D. Administer antibiotics for suspected pneumonia. Answer: B. Administer nitroglycerin and furosemide. Explanation: the patient's presentation of shortness of breath, orthopnea, and edema suggests acute decompensated heart failure (AHFA). The immediate treatment involves reducing preload and afterload to improve cardiac function. Nitroglycerin helps to reduce afterload and preload by dilating blood vessels, while furosemide is a diuretic that reduces fluid overload administered. Roman IIIDS option A is contraindicated in heart failure as it could worsen fluid retention. Epinephrine option C is used for anaphylaxis, and antibiotics option D would be indicated only if there were signs of infection such as fever or productive cough, which are not present here. Question 6. A 72-year-old woman with a history of type 2 diabetes presents with confusion, diaphoresis, and trembling. She is diaphoretic and weak, and her blood glucose level is 4 mg/dL. What is the most appropriate initial intervention? A. Administer glucagon intramuscularly. B. Administer an oral dose of insulin. C. Provide a dose of glucose orally if the patient is alert. D. Initiate an intravenous insulin infusion. Answer: C. Provide a dose of glucose orally if the patient is alert. Explanation: this patient's symptoms, confusion, diaphoresis, trembling, and low blood glucose level 4 mg/dL indicate hypoglycemia. The first-line intervention in conscious patient is to administer glucose orally, option C. If the patient were unconscious, glucagon, option A, would be given, but in this case, oral glucose is preferred if the patient can swallow. Insulin, option B and D, would lower blood glucose further and is not appropriate in the treatment of hypoglycemia. Oral glucose is a rapid-acting source of sugar that can help correct the hypoglycemic state. Question 7, scenario-based. Mr. Watson, a 45-year-old male, arrives at the emergency department after being involved in a car accident. He is awake but complains of severe abdominal pain and nausea. On examination, he has a rigid abdomen and his vital signs are BP 90, 60, HR 120, RR 22, and SPO 94%. A focused assessment reveals tenderness in the lower abdomen. What is the most likely diagnosis and what is the priority intervention? A. Acute pancreatitis. Administer Roman IIIDS and pain management. B. Abdominal compartment syndrome. Initiate immediate surgical consultation. C. Ruptured spleen. Perform an abdominal CT scan and prepare for surgery. D. Abdominal trauma with possible internal bleeding. Stabilize and prepare for surgery. Answer: D. Abdominal trauma with possible internal bleeding. Stabilize and prepare for surgery. Explanation: Mr. Watson's presentation, including rigid abdomen, hypotension, tachycardia, and lower abdominal tenderness, suggests abdominal trauma with possible internal bleeding, e.g., splenic rupture, liver injury, or bowel perforation. The priority in this case is to stabilize the patient, Roman IIID, oxygen, and monitoring. Prepare for urgent surgical intervention. CT scan may be necessary, but the immediate concern is to stabilize the patient in preparation for surgery, not waiting for imaging, option C. Acute pancreatitis, option A, typically presents with epigastric pain and is not associated with trauma or hypotension. Abdominal compartment syndrome, option B, is a rare condition that would require pressure monitoring, but it is less likely given acute trauma and absence of abdominal distension. Question 8. A 30-year-old female presents with an episode of generalized tonic-clonic seizures. Her vital signs are stable, and she is currently post-ictal. She has no significant medical history. What is the most appropriate immediate treatment? A. Administer lorazepam intravenously. B. Place the patient on a cardiac monitor and observe for 12 hours. C. Administer sodium bicarbonate to correct metabolic acidosis. D. Secure the patient's airway and wait for the seizure to resolve. Answer A. Administer lorazepam intravenously. Explanation: in a patient presenting with a generalized tonic-clonic seizure, the most appropriate immediate treatment is the administration of a benzodiazepine, such as lorazepam, which acts rapidly to stop the seizure. Seizures lasting more than 5 minutes or recurrent seizures require urgent pharmacological intervention. Option B is incorrect, as prolonged observation without treatment is inappropriate. Sodium bicarbonate, option C, is used for specific cases of metabolic acidosis, not for seizures. While securing the airway, option D, is crucial if the patient becomes unresponsive. Immediate administration of a seizure-abortive agent, such as lorazepam, is the priority. Question 9. A 45-year-old male with no known allergies presents with acute onset of severe chest pain radiating to his left arm, accompanied by shortness of breath and diaphoresis. His ichthyosis and segment elevation in leads VVV. What is the first step in management? A. Administer oxygen and prepare for immediate thrombolysis. B. Administer aspirin, nitroglycerin, and contact the cardiac team for urgent intervention. C. Start heparin therapy immediately to prevent clot formation. D. Perform a focused ultrasound of the heart to rule out pericarditis. Answer B. Administer aspirin, nitroglycerin, and contact the cardiac team for urgent intervention. Explanation: this patient's symptoms and ECG findings are indicative of an acute STEMI. The first step in managing STEMI is the administration of aspirin to reduce platelet aggregation, followed by nitroglycerin to reduce myocardial oxygen demand, and then contacting the cardiac team for urgent intervention, including PCI. Therapy option A may be beneficial but is not the first priority. Heparin option C may be given after the initial management but is not the first-line intervention. Focused ultrasound option D is unnecessary in the case of STEMI and would delay appropriate treatment. Question 10. A 60-year-old male with a history of chronic alcoholism presents with confusion, lethargy, and tremors. He has a low serum glucose level and his alcohol level is elevated. What is the most appropriate initial intervention? A. Administer omoniamine followed by glucose. B. Administer naloxone to reverse opioid toxicity. C. Administer omnileucose followed by thiamine. D. Administer ominoids with dextrose alone. Answer C. Administer omnileucose followed by thiamine. Explanation: this patient's symptoms are suggestive of alcohol-induced hypoglycemia and Wernicke's encephalopathy due to thiamine deficiency. The initial treatment is to administer omnileucose to correct hypoglycemia. Thiamine should be given after glucose to prevent precipitating or worsening Wernicke's encephalopathy, life-threatening condition caused by thiamine deficiency. Option is incorrect because glucose should be administered first, followed by thiamine. Naloxone, option B, is used to reverse opioid overdose and is not indicated in this case. Dextrose alone, option D, could exacerbate the thiamine deficiency and lead to neurological damage. Question 11. A 25-year-old female presents to the emergency department with complaints of severe lower abdominal pain and vaginal bleeding. She reports a history of irregular periods and has missed her last period. A pregnancy test is positive. On examination, her vital signs are stable, but she has moderate abdominal tenderness. Her pelvic ultrasound shows an empty uterus and there is free fluid in the pelvis. What is the most likely diagnosis? A. Ectopic pregnancy. B. Spontaneous abortion. C. Endometriosis. D. Ovarian cyst rupture. Answer A. Ectopic pregnancy. Explanation: the patient's positive pregnancy test, lower abdominal pain, vaginal bleeding, and free fluid in the pelvis are concerning for an ectopic pregnancy, which occurs when the fertilized egg implants outside the uterus, most commonly in the fallopian tube. The ultrasound showing an empty uterus and free fluid suggests that there may be bleeding into the abdomen due to ruptured ectopic pregnancy, which is emergency. Spontaneous abortion, option B, could cause similar symptoms, but the ultrasound findings would show an incomplete pregnancy or retained product of conception. Endometriosis, option C, typically presents with pelvic pain but would not cause an empty uterus or free fluid. Ovarian cyst rupture, option D, can also cause abdominal pain and bleeding but would not typically present with positive pregnancy test. Question 12. A 63-year-old male with a history of hypertension and smoking presents with sudden onset severe chest pain radiating to his back. He is diaphoretic and anxious. On examination, his blood pressure is 210 on 100 Tag, and there is a pulse differential between the left and right arms. What is the most likely diagnosis? A. Acute myocardial infarction. B. Acute aortic dissection. C. Pulmonary embolism. D. Pericarditis. Answer: B. Acute aortic dissection. Explanation: this patient's presentation of sudden onset severe chest pain radiating to his back along with hypertension, pulse differential, and the described physical exam findings is highly suggestive of an acute aortic dissection. Aortic dissection often presents with sharp tearing chest pain that radiates to the back and can cause pulse differential due to obstruction of blood flow in one of the branches of the aorta. Acute myocardial infarction, option A, would present with chest pain and possibly radiation to the arms, but it typically does not cause pulse differences. Pulmonary embolism, option C, would present with pruritic chest pain, shortness of breath, and hypoxia, not the pattern seen here. Pericarditis, option D, typically causes sharp pruritic chest pain that improves with sitting up and does not cause pulse differential. Question 13. A 40-year-old male with no significant medical history presents with a sudden onset of right-sided weakness and difficulty speaking. He is alert and oriented but has expressive aphasia and right hemiparesis. A eukaryote of the brain reveals a hyperdense area in the left middle cerebral artery and Mackay territory. What is the most appropriate next step in management? A. Administer tissue plasminogen activator, TPA. B. Initiate anticoagulation therapy. C. Perform a lumbar puncture. D. Observe and monitor the patient for 24 hours. Answer: A. Administer tissue plasminogen activator, EPA. Explanation: this patient presents with the classic signs of an acute ischemic stroke, sudden onset weakness, expressive aphasia, and CT findings suggestive of an Mackay stroke. The appropriate next step is to administer tissue plasminogen activator, TPA, within the first 4.5 hours of symptom onset, as it can help dissolve the clot and restore blood flow to the affected brain area. Anticoagulation, option B, is not the first-line treatment for acute ischemic stroke, as it can increase the risk of hemorrhagic transformation. Lumbar puncture, option C, is not indicated in this case, as the diagnosis is already clear with the CT scan findings. Observation, option D, would be inappropriate, as the patient requires urgent treatment. Question 14, scenario-based. A 55-year-old male with a history of chronic obstructive pulmonary disease, COPD, presents with increasing shortness of breath and cough with greenish sputum for the past 3 days. On examination, he has bilateral wheezing and decreased breath sounds at the bases. His oxygen saturation is 88% on room air. What is the most likely cause of his symptoms, and what is the best next step in management? A. Acute exacerbation of OT. Administer bronchodilators and steroids. B. Community-acquired pneumonia. Initiate broad-spectrum antibiotics. C. Pulmonary embolism. Initiate anticoagulation therapy. D. Acute heart failure. Administer diuretics and oxygen. Answer: A. Acute exacerbation of COPD. Administer bronchodilators and steroids. Explanation: this patient with COPD who presents with worsening shortness of breath, cough with greenish sputum, and hypoxia is most likely experiencing an acute exacerbation of COPD, often triggered by infection or environmental factors. The best next step is to administer bronchodilators, such as albuterol, and systemic steroids to reduce inflammation and efflow. While pneumonia, option B, could also cause similar symptoms, the presence of wheezing and COPD history makes an exacerbation more likely. Pulmonary embolism, option C, typically presents with sudden onset pruritic chest pain and dyspnea, and the clinical findings here are more suggestive of an infection or inflammation. Acute heart failure, option D, might present with shortness of breath but would usually cause bilateral crackles, orthopnea rather than wheezing, and productive cough. Question 15. A 32-year-old female presents with fatigue, weight gain, and cold intolerance. She reports a history of dry skin, constipation, and depression. On physical examination, her skin is dry and she has delayed reflexes. Her thyroid-stimulating hormone (TSH) level is elevated and free thyroid sign is low. What is the most likely diagnosis? A. Hashimoto's thyroiditis. B. Graves' disease. C. Subclinical hyperthyroidism. D. Primary hyperparathyroidism. Answer: A. Hashimoto's thyroiditis. Explanation: this patient's symptoms of fatigue, weight gain, cold intolerance, dry skin, and constipation, along with the laboratory findings of elevated TSH and low Freet, are consistent with hypothyroidism, specifically Hashimoto's thyroiditis. Hashimoto's thyroiditis is an autoimmune disorder in which the immune system attacks the thyroid gland, leading to its dysfunction. Graves' disease, option B, cause of hypothyroidism, and would present with symptoms of weight loss, heat intolerance, and tremors, not the symptoms described here. Subclinical hypothyroidism, option C, would show low TH with normal T, and primary hyperparathyroidism, option D, typically presents with hypocalcemia and does not cause hypothyroid symptoms. Question 16. A 72-year-old female with a history of hypertension and diabetes presents with sudden onset of visual disturbances in her left eye described as a curtain coming down, as she reports no pain but has difficulty seeing out of her left eye. On examination, her visual acuity is reduced in the left eye, and a fundoscopy shows a retinal detachment. What is the most likely cause of her retinal detachment? A. Diabetic retinopathy. B. Hypertensive retinopathy. C. Age-related macular degeneration. D. Posterior vitreous detachment. Answer D. Posterior vitreous detachment. Explanation: retinal detachment often occurs due to a posterior vitreous detachment (PVD), where the vitreous gel within the eye pulls away from the retina. This process can cause a curtain or veil sensation in the visual field, while diabetic retinopathy, option A, and hypertensive retinopathy, option B, can lead to vision problems. They typically cause retinal changes such as microaneurysm, hemorrhages, and exudates, rather than a retinal detachment. Age-related macular degeneration, option C, is a degenerative disease affecting the macula, which typically leads to central vision loss rather than the symptoms described here. Question 17. A 50-year-old male presents to the emergency department with severe left-sided chest pain radiating to his back. He also reports shortness of breath and dizziness. On examination, his blood pressure is 100 Hg and his pulse is 100 EM. A chest X-ray shows a widened mediastinum. What is the most likely diagnosis? A. Acute myocardial infarction. B. Aortic dissection. C. Pulmonary embolism. D. Pneumothorax. Answer B. Aortic dissection. Explanation: the combination of severe chest pain radiating to the back, shortness of breath, dizziness, and a widened mediastinum on chest X-ray is highly suggestive of an aortic dissection. The high blood pressure may contribute to the tear in the aorta. Aortic dissection presents with a sudden onset, sharp tearing chest pain that may radiate to the back and is often associated with a widened mediastinum on imaging. Acute myocardial infarction, option A, typically causes chest pain, but it is not associated with a widened mediastinum. Pulmonary embolism, option C, can cause chest pain and shortness of breath, but it would not cause a widened mediastinum. Pneumothorax, option D, usually presents with pleuritic chest pain and dyspnea without the findings of a widened mediastinum. Question 18. A 68-year-old female presents with difficulty swallowing and regurgitation of food. She reports a sensation of food sticking in her chest. On further questioning, she denies heartburn or chest pain. A barium swallow reveals a bird beak appearance at the lower esophagus. What is the most likely diagnosis? A. Achalasia. B. Gastroesophageal reflux disease (GERD). C. Esophageal cancer. D. Peptic ulcer disease. Answer A. Achalasia. Explanation: the patient's symptoms of difficulty swallowing, regurgitation, and the bird beak appearance on barium swallow are characteristic of achalasia. Achalasia is a motility disorder in which the lower esophageal sphincter fails to relax properly, leading to a backup of food in the esophagus. GERD, option B, typically presents with heartburn and regurgitation, but it does not cause a bird beak appearance on imaging. Esophageal cancer, option C, may cause dysphagia, but it usually presents with progressive symptoms and weight loss, not a bird beak sign. Peptic ulcer disease, option D, can cause epigastric pain, but it does not explain the symptoms of difficulty swallowing and the radiologic finding. Question 19, scenario-based. A 45-year-old male with a history of alcohol abuse presents with confusion, ataxia, and ophthalmoplegia. He is unable to perform rapid alternating movements with his hands, and his gait is unsteady. His liver function tests are elevated, and his serum thiamine level is low. What is the most likely diagnosis, and what is the recommended treatment? A. Wernicke-Korsakoff syndrome. Administer thiamine. B. Alcoholic cerebellar degeneration. Administer corticosteroids. C. Acute alcohol intoxication. Provide Romanuids and monitoring. D. Hepatic encephalopathy. Administer lactulose. Answer A. Werner-Korsakoff syndrome. Administer thiamine. Explanation. This patient's presentation of confusion, ataxia, ophthalmoplegia, and history of alcohol abuse is most consistent with Werner-Korsakoff syndrome, which is caused by thiamine, vitamin B deficiency. This deficiency is common in chronic alcoholics and leads to acute symptoms of Wernicke's encephalopathy, which includes the classic triad of confusion, ataxia, ophthalmoplegia. The recommended treatment is the administration of thiamine to prevent progression to the more severe Korsakoff syndrome. Alcoholic cerebellar degeneration, option B, presents with cerebellar signs, but it is not associated with confusion and ophthalmoplegia. Acute alcohol intoxication, option C, would present with acute central nervous system depression but not the signs seen here. Hepatic encephalopathy, option D, is associated with liver failure and presents with confusion and altered mental status, but it does not explain the neurological findings. Question 20. A 40-year-old male presents with a painless testicular lump and mild scrotal swelling. On examination, the lump is firm, non-tender, and irregular in shape. The patient reports no history of trauma or infection. A scrotal ultrasound shows a hypoechoic mass in the testicle. What is the most likely diagnosis? A. Testicular torsion. B. Epididymitis. C. Testicular cancer. D. Hydrocele. Answer. C. Testicular cancer. Explanation. A painless, firm, non-tender, irregular testicular mass in a patient without trauma or infection is most likely testicular cancer. Testicular cancer often presents as a painless testicular lump, and the scrotal ultrasound findings of a hypoechoic mass support this diagnosis. Testicular torsion, option A, is characterized by sudden onset pain and swelling, often accompanied by nausea and vomiting, and not present as a painless mass. Epididymitis, option B, presents with scrotal pain and swelling, typically associated with infection or urinary symptoms and would not present as a painless mass. A hydrocele, option D, is a fluid-filled sac around the testicle, typically presenting as scrotal swelling without a firm mass. Question 21. A 60-year-old male presents to the clinic complaining of progressive fatigue, weight loss, and a painless lump in his neck. On physical exam, there is a firm, non-tender lymph node enlargement in the left cervical region. He also has hepatomegaly and splenomegaly. A complete blood count reveals an elevated white blood cell count with a predominance of mature lymphocytes. What is the most likely diagnosis? A. Acute lymphoblastic leukemia. B. Chronic lymphocytic leukemia. C. Hodgkin's lymphoma. D. Non-Hodgkin's lymphoma. Answer. B. Chronic lymphocytic leukemia. Explanation. The patient's progressive fatigue, weight loss, painless lymphadenopathy, hepatomegaly, splenomegaly, and elevated white blood cell count with mature lymphocytes are most consistent with chronic lymphocytic leukemia CLL often presents with painless lymphadenopathy and splenomegaly with an elevated white blood cell count containing predominantly mature lymphocytes, acute lymphoblastic leukemia. Or option A, typically presents with more severe symptoms such as fever, anemia, and thrombocytopenia and involves immature lymphoblasts. Hodgkin's lymphoma, option C, and non-Hodgkin's lymphoma, option D, can cause lymphadenopathy, but the presence of a predominance of mature lymphocytes and the chronic nature of the symptoms suggests CL. Question 22. A 25-year-old female presents with a butterfly-shaped rash across her cheeks and nose, photosensitivity, and joint pain. She has a positive anti-nuclear antibody on a test. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Systemic lupus erythematosus. C. Psoriatic arthritis. D. Dermatomyositis. Answer. B. Systemic lupus erythematosus. Explanation. The butterfly-shaped rash across the cheeks and nose, photosensitivity, joint pain, and a positive on a test of classic features of systemic lupus erythematosus. SLE. SLE is an autoimmune disorder that can affect multiple organ systems and is often associated with a positive on a test. Rheumatoid arthritis, option A, typically presents with symmetric joint pain and swelling involving the hands and wrists and is not characterized by the skin rash seen here. Psoriatic arthritis, option C, can cause joint pain and skin involvement, but it is associated with psoriasis, which is not mentioned here. Dermatomyositis, option D, can present with a rash, but it typically involves the eyelids. A heliotrope rash, not the butterfly rash of SLE. Question 23. A A 55-year-old male presents with sudden onset severe abdominal pain, nausea and vomiting. He has a history of hypertension and smoking. On examination, he has a pulsatile mass in the abdomen. What is the most likely diagnosis? A. Acute pancreatitis. B. Abdominal aortic aneurysm rupture. C. Bowel obstruction. D. Peptic ulcer perforation. Answer: B. Abdominal aortic aneurysm rupture. Explanation: the combination of sudden onset severe abdominal pain, nausea, vomiting, a history of hypertension and smoking, and a pulsatile abdominal mass is highly suggestive of a ruptured abdominal aortic aneurysm. It often presents with severe tearing abdominal pain and a pulsatile mass on abdominal examination. The patient's risk factors of hypertension and smoking further increase the likelihood of this diagnosis. Acute pancreatitis option A presents with epigastric pain radiating to the back but does not involve pulsatile mass. Bowel obstruction option C typically presents with crampy abdominal pain, distension, and vomiting but lacks pulsate mass. Peptic ulcer perforation option D can cause sudden onset severe abdominal pain but does not present with pulsatile mass. Question 24, scenario based. A 60-year-old female with a history of smoking presents with a persistent cough, hemoptysis, and weight loss. A chest X-ray shows a mass in the right lung with mediastinal lymphadenopathy. What is the most likely diagnosis and what is the next step in management? A. Chronic obstructive pulmonary disease. COP to prescribe inhalers. B. Pulmonary tuberculosis. Initiate anti-tuberculosis therapy. C. Lung cancer. Refer for biopsy. D. Pneumonia. Prescribe antibiotics. Answer: C. Lung cancer. Refer for biopsy. Explanation: the patient's history of smoking, persistent cough, hemoptysis, weight loss, and radiologic findings of lung mass with mediastinal lymphadenopathy are most consistent with lung cancer. The next step in management is to refer for biopsy to confirm the diagnosis and determine the type of lung cancer, e.g., non-small cell lung cancer or small cell lung cancer. Chronic obstructive pulmonary disease. COPT option A can present with chronic cough, but it does not cause hemoptysis or weight loss, nor does it show mass on chest X-ray. Pulmonary tuberculosis option B can cause persistent cough and weight loss, but the X-ray findings are more suggestive of lung cancer. Pneumonia option D typically presents with fever, productive cough, and lung infiltrates and would not cause mass or mediastinal lymphadenopathy. Question 25. A 45-year-old male presents with a painful red, swollen right knee. He reports that the pain started suddenly and has progressively worsened over the past 24 hours. He has a history of hyperuricemia but is not currently taking medication for it. What is the most likely diagnosis? A. Septic arthritis. B. Gout. C. Osteoarthritis. D. Rheumatoid arthritis. Answer: B. Gout. Explanation: the patient's sudden onset of pain, redness, and swelling in the right knee along with a history of hyperuricemia is highly suggestive of gout. Gout is caused by the deposition of uric acid crystals in the joints, leading to acute severe inflammation, often affecting the big toe, but can involve other joints such as the knee. Septic arthritis option A can cause similar symptoms but would typically be associated with fever. Require a joint aspiration to rule out infection. Osteoarthritis option C presents with gradual onset of joint pain and stiffness, particularly in weight-bearing joints, but it does not present with the acute inflammatory symptoms seen here. Rheumatoid arthritis option D usually presents with symmetrical joint involvement, including the hands and wrists, and is not associated with hyperuricemia or the acute onset seen here. Question 26. A 70-year-old male with a history of coronary artery disease presents to the emergency department with chest pain. The pain is described as crushing and radiates to his left arm. He is diaphoretic and feels nauseous. His vital signs include a heart rate of 100 EPM, blood pressure of 149 mmHg, and a respiratory rate of 18. An electrocardiogram shows an elevation in the anterior leads. What is the most appropriate next step in management? A. Administer sublingual nitroglycerin. B. Initiate intravenous heparin. C. Start oral aspirin. D. Prepare for percutaneous coronary intervention ECI. Answer: D. Prepare for percutaneous coronary intervention ECI. Explanation: The patient's presentation of crushing chest pain radiating to the left arm, diaphoresis, nausea, and findings of segment elevation in the anterior lead strongly suggests an acute elevation myocardial infarction STEMI. The most appropriate next step in management is to prepare for percutaneous coronary intervention ECA, which is the gold standard for revascularization in STEMI. Ministering sublingual nitroglycerin, option A, may be helpful for chest pain relief, but is not the definitive treatment. Intravenous heparin, option B, is commonly used in STEMI management but does not address the need for immediate revascularization. Oral aspirin, option C, is important for antiplatelet therapy but is not the immediate next step in this urgent scenario. Question 27. A 30-year-old female presents with a complaint of painful, swollen joints, particularly in the wrists and fingers, that have been present for the past few weeks. She also reports feeling fatigued and having morning stiffness. On physical exam, there is swelling and tenderness in the proximal interphalangeal joints and metacarpophalangeal joints. What is the most likely diagnosis? A. Osteoarthritis. B. Rheumatoid arthritis. C. Psoriatic arthritis. D. Gout. Answer: B. Rheumatoid arthritis. Explanation: the patient's symptoms of painful, swollen joints, particularly in the wrists and fingers, along with morning stiffness and fatigue, are classic signs of rheumatoid arthritis. RART typically presents with symmetric joint involvement, particularly in the small joints of the hands and wrists, and is associated with morning stiffness lasting for at least 30 minutes. Osteoarthritis, option A, is characterized by joint pain and stiffness, but typically affects larger joints and shows a gradual onset without the symmetric swelling and morning stiffness. Psoriatic arthritis, option C, can affect the fingers, but is associated with psoriasis. Gout, option D, causes acute pain, often in the big toe, and is associated with hyperuricemia, but it typically does not affect multiple joints symmetrically. Question 28, scenario-based. A 45-year-old male with a history of alcohol use disorder presents to the emergency department with confusion, ataxia, and nystagmus. His gait is unsteady, and he appears to have difficulty walking in a straight line. He has not been drinking alcohol for several days. His serum vitamin B, thiamine, level is low. What is the most likely diagnosis? A. Wernicke's encephalopathy. B. Korsakoff syndrome. C. Delirium tremens. D. Alcoholic ketoacidosis. Answer: A. Wernicke's encephalopathy. Explanation: the patient's confusion, ataxia, nystagmus, and history of alcohol use disorder are highly suggestive of Wernicke's encephalopathy, which is due to thiamine, vitamin B deficiency. This condition is most commonly seen in chronic alcoholics who are malnourished. The symptoms of Wernicke's encephalopathy are acute and include confusion, ataxia, and ophthalmoplegia, nystagmus. Korsakoff syndrome. B is long-term complication of thiamine deficiency that involves memory deficits, particularly anterograde amnesia and confabulation, but it is not typically associated with the acute presentation seen here. Delirium tremens, option C, occurs in alcohol withdrawal and is characterized by tremors, agitation, confusion, and hallucinations, but is not associated with nystagmus or ataxia. Alcoholic ketoacidosis, option D, presents with metabolic acidosis and fruity odor to the breath, but does not cause the neurological symptoms seen in this patient. Question 29. A 55-year-old male with a history of hypertension and smoking presents to the clinic complaining of new-onset shortness of breath and a persistent cough. He also reports a 10-pound weight loss over the past few months. On examination, there is decreased breath sounds and dullness to percussion on the right side of the chest. Chest X-ray reveals a large pleural effusion on the right side. What is the most likely diagnosis? A. Congestive heart failure. B. Pulmonary embolism. C. Lung cancer with pleural effusion. D. Tuberculosis. Answer: C. Lung cancer with pleural effusion. Explanation: the patient's symptoms of shortness of breath, cough, weight loss, and physical exam findings of dullness to percussion and decreased breath sounds on the right side of the chest, along with a large pleural effusion seen on chest X-ray, are highly suggestive of lung cancer with associated pleural effusion. Lung cancer is a common cause of malignant pleural effusion, and the weight loss and smoking history. Risk factors for lung cancer: congestive heart failure, option A, can cause pleural effusions but is usually associated with bilateral effusions. Pulmonary embolism, option B, can cause acute shortness of breath but would not cause a pleural effusion as the primary finding. Tuberculosis, option D, can cause pleural effusion, but it is less likely to present with weight loss and a persistent cough without other constitutional symptoms like or night sweats. Question 30. A 25-year-old female presents with a 2-week history of severe crampy abdominal pain, bloating, and diarrhea. She has noticed that the symptoms worsen after eating. She reports that she has had similar episodes in the past, but that they were less severe. She has no significant medical history. What is the most likely diagnosis? A. Irritable bowel syndrome. B. Inflammatory bowel disease. C. Lactose intolerance. D. Celiac disease. Answer A. Irritable bowel syndrome. Explanation: the patient's symptoms of crampy abdominal pain, bloating, and diarrhea that worsen after eating are most consistent with irritable bowel syndrome (IBS). It is a functional gastrointestinal disorder characterized by recurrent abdominal pain and changes in bowel habits, often related to eating. Inflammatory bowel disease (option B), including Crohn's disease and ulcerative colitis, presents with more severe symptoms such as weight loss, bloody diarrhea, and fever. Lactose intolerance (option C) can cause bloating and diarrhea after consuming dairy products, but it typically does not cause abdominal pain. Celiac disease (option D) presents with symptoms of malabsorption, including diarrhea, weight loss, and vitamin deficiencies, but is usually associated with a history of gluten intolerance and positive celiac serology.